Okay, good afternoon. I try to present a complex case, but I hope to be beneficial to all of you. Yeah, it's okay. So my case was 50 years old, male patient, and his cardiovascular risk factor, he's diabetic and hyperlipidemic. His presentation was an ST elevation myocardial infarction. Hemodynamic was stable. The ECG showed there is diffuse ST segment depression and some ST segment elevation in the AVR. Resting echocardiography was fair LV systolic function, and estimated EF was 50%, and there was intraseptal intra-apical hypokinesis. Serum troponin was significantly elevated. So we bring the patient to the cath lab, and this is the axis was this is the right coronary artery. It's clearly free from the disease in two views, and the left system here. We can appreciate there is tight disease left main, and there is total osteoproximal, functionally total osteoproximal LID, and there is some atheroma at the osteal circ. So my plan to negotiate the LID, it was very easy by using, this is another spider view, looking for the left main and the osteoproximal LID and the circ. And this is areocranial view. So I easily wired the LID using folder FC with the balloon support, and then multiple balloon dilatation was performed using different size balloon, and then first stent was deployed. After that, the stent balloon withdrawal a little bit and go with high pressure for further optimization of the stent. Control angio, we can appreciate here there's a dissection in the left main and osteoproximal LID. So the second stent was deployed and a little overlap with the first stent. Thereafter, the stent balloon withdrawal further and for further optimization and flaring under very high pressure. After that, further optimization. And here, the patient got abnormal movement and started suffering from the severe radial right arm pain, which was explained at that time because of the radial spasm. And despite of heavy sedation, I couldn't advance the catheters or guide catheter to engage the mouth of the left main stem. So I decided to cross over to the femoral approach, and despite of using different type of the guides in form of the Judkin 3.54 and EBU guide catheters, very difficult or hardly difficult to cannulate the mouth of the stent. So this view, there is a wire inside the LID because even with the non-selective shoot, I can't obfuscate the left main circ and LID. That's why I'm going to cut the guide cutter to the side of the left main stem and negotiate the left main stem by the wire. And I'm realize here there is significantly overhanging stent by at least 5 millimeter in the aorta. So the result in the left main seam, the stent, it's okay, and the circ, there is TIM3 flow, and the LID fine. So my question for my colleague, just one suggestion, shall we stop here or we can proceed for further optimization of the left main LID and circ? Any comment? Just one suggestion.
The question, before the suggestion, the question is that why this part of a stent was in aorta. It was deliberately left in aorta, then problem starts.
No.
Number two, I think circumflex is very severe pinch, so that must be tackled.
So yeah,
it may cause a lot of pain in this patient.
So exactly, I agree with you. The circumflex is significantly pinched, and it seems to be a big circ and supplying large area of the myocardium. So I decide to. Do you have any comments? Okay, you can go ahead.
Snare it and remove it.
Sorry.
Snare and remove.
Snare and remove. So okay, this is a very good option. But the patient was very unstable because of because his anatomy, and he got an anastomia with high troponin and ongoing chest pain. So I decided to proceed with the procedure or angioplasty through the stent cell. Although there is some
Can you get?
Yes, there is no video before. I wiring the left main stem through the stent cell. Yeah. Okay, because it was very difficult to cannulate the mouth of the stent. That's why the only way to me to negotiate the left main stem through the stent cell. So my decision was to complete the procedures or complete the angioplasty through the stent cell and try to optimizing the left main and osteal circ. So So this is an optimization. Start with upgrading the balloon size. Start with 2.5, 3.5, and 4.5 to widely open and create a new orifice for future revascularization to become more easy.
So we heard snaring. Hassan.
Yeah.
What do you think was snaring?
Sorry, Khalid.
No, I mean, it's fine. I mean, so the main question is the stent is hanging in the, half of the stent in the aorta, right? So one is leave it, don't do anything. Two is take a microcatheter and rescue the circ because you already wired it. Three is you can, because my worry, sometimes you can even crush the stent against the wall. You take a balloon and inflate it and crush it. But if I do that, I may compromise the ostium of the circ more. So these are the options that you have. Or the fourth.
Stay with me.
The fourth one is actually, and we've done that accidentally. You take a jail guide, you go below the stent, you wire it from below, and you open the strut and basically splitting the stent in the aorta.
لا تخوف. هذا بشيء سهل. اللي تخوفون الناس. Okay. What happened?
Okay. Go for another slide. So I appreciate here there is significantly pinch, and we are upgrading the balloon size 2.5, 3.5, and 4.5 to create a new orifice to make the future revascularization more easier. So then I am wiring the circ was very easy. Then. Okay, this is the kissing balloon 2.75 for the circ and 3.5 for the LID. But unfortunately, the result after a final kissing balloon dilatation was suboptimal. So I decided to stenting the circ. Yes. And then, so this is a 3.0 by 18. My approach was inverted crush. This is the stent and protruded approximately 2-3 millimeter inside the left main and the balloon and the LID. Then, after deployment of the stent, the crushing by 3.5 NC balloon. Okay, next. Okay, this is the recross through crushing balloon. Crushing stent was very easy, and this is a final kissing balloon dilatation, 3.0 and 3.5 for the LID, and this is the final result. Okay. So my key messages, the PCI of the ortho-osteal lesions are challenging angioplasty procedures. During the initial stenting, the stent size placement should be very well adjusted to ensure the minimal stent protrusion to the aorta as much as possible. Too much overhanging of the stent into the aorta at the first intervention, it will increase the possibility of the ISR, failure of the coaxial and selective cannulation of the coronary ostium and the guide wire advancement. Excessively overhanging stent PCI may require alternative and complex technique such as double wire technique, balloon assisted technique, double lumen microcatheters, and side strut sequential balloon technique, and guide liner assisted side, and strut stenting technique. And thank you very much.
Thank you very much.